Welcome to our session. We're going to be talking more about salivary gland tumors tonight, this morning, wherever you are. So stay tuned. Well, welcome everyone. We're glad to be together again. I'm sorry for the confusion about last week. Partly my fault, for sure, getting the month straight. But I'm glad we're back together, and we have lots more good cases of salivary gland lesions to talk about. And we'll enable the transcript so you can understand me more easily. And I'll also try to speak slowly. But if we have questions as we go along, don't hesitate to put those in the chat or raise your hand or even just unmute yourself and ask a question so that we can have the best interchange on the topic tonight. So I'm going to go ahead and share the screen here as we talk about salivary gland lesions. We talked a little about last time normal morphology and some of the adenomas. I think I was a little confused on the newer terminology. Basal cell adenoma has replaced monomorphic adenoma. So both of those lesions were the same lesion. But we'll start tonight with a variant on that, which is sebaceous adenoma. And this is also a benign lesion. And as you can imagine, it has essentially just sebaceous type differentiation. It can come in a solid versus a cystic pattern. And it may have some elements of normal ductal cells present as well, as you can see here. So areas with clearly recognizable sebaceous differentiation should be present. As you can see in some of these glandular cells here, we have fairly characteristic sebaceous type cells with foamy granular cytoplasm and central nuclei. But we also have other cells around, as you can see, more oncocytic type cells here and some more canalicular or ductal type cells. So it may not be a pure sebaceous differentiation, but as you can see, there are clear areas of sebaceous type differentiation. As you noted from the low magnification, this looks a lot like a pleomorphic adenoma. It's got stroma and it's got epithelial cells. It's got a pretty sharp border here. So this is really just a variation on the sebaceous, on a pleomorphic adenoma, but with areas of sebaceous differentiation as we've highlighted here. Now, sometimes these lesions can become partly cystic. And this is the second lesion that we have here, which has a more cystic feature. Here you see the border between normal salivary parotid gland and this lesion, which doesn't look particularly sebaceous at low magnification, and in fact has quite a bit of more squamoid features. But then as you come into higher magnification, you can see there will be areas of sebaceous type differentiation in areas, almost more like a lymphoepithelial cyst or a squamous epithelial inclusion. So if you don't call it sebaceous and think that this is more squamoid, that's not a big problem. But as you can see, it's sort of making a sebaceous type of secretion here. It's not making the usual keratinized squamous epithelial secretion. It's this more foamy type of pattern. So it's a bit of a challenging call in some respects, but I think you can see there's a degree of this sort of central foamy type change, even though many of the cells have sharp cell borders. But you'll notice that the epithelial cells, uniformly round nuclei, they're very bland appearing. And this lesion also has sort of a lymphoid stroma, so it might even be in the realm or differential for a Werthin's type tumor with sebaceous type differentiation. Just a variety of variations on the theme in the salivary gland that make our tumors here so interesting and diverse. I don't think any of you would have difficulty in classifying this as benign, given the very sharply circumscribed nature of the lesion, the degree of differentiation that's being manifest here, and very mild or no significant atypia. Cystic sebaceous adenoma or cystic adenoma with sebaceous differentiation. All right, well, let's go on to one of the new entities in the WHO classification. And this is something that I could not find a good representative slide for, but I do have some good photographs. So we'll talk a little bit about it. This is relatively uncommon, but you remember we saw some of those sclerosing lesions last time. And so this is also a lesion which is sclerosing, but also has numerous cystic components. These tend to be well circumscribed and encapsulated, so not hard to classify as an adenoma. And the makeup is quite variable. You have both acinar epithelium, some ducts, this very fibrotic stroma, and even occasionally some fat. Now, there can be variable foci of atypia, ranging from fairly low grade to even potentially high grade. But again, they'll usually be fully encapsulated, so you won't be inclined to call them carcinoma. Interestingly, the low-grade atypia characteristically is SOX10 positive, whereas the high-grade atypia is more frequently associated with androgen receptor positivity. So more akin to some of the ductal type of carcinomas that we'll see later where androgen positivity is seen. So here's some representative images from publications. You can see the fat. You can see the admixed acinar epithelium, ductal type epithelium, some lymphocytes. Here you see the sclerosis and so forth. So there it is, all three elements, the sclerosing polycystic adenoma with those kind of features. And you can see there's not very much atypia here. Here is another field where we begin to see a little bit more atypia, a little bit more sort of like a ductal carcinoma in situ type of appearance with this slightly cribriform area, a little bit higher grade. And here you can see the SOX10 positivity associated with this low-grade atypia. Now here, as we get a little bit higher grade atypia and the sclerosis, it might be more concerning to think about possibly invasive neoplasia or a ductal type of carcinoma. Here you see more of an apocrine type of appearance with some necrotic debris in the lumina. But remember, these foci tend to be localized. So this may be one of the precursor lesions to some of the ductal tumors that we'll talk about, but it has been recognized now as a separate entity, and therefore you can use this term sclerosing polycystic adenoma, plus or minus low-grade dysplasia, high-grade dysplasia, et cetera, as a possible description of this lesion. All right, well, let's go on to a much more frequently encountered lesion, the myoepithelioma. And of course, this is a category of cells that are seen in the salivary glands and also in other areas in the body, particularly the breast and so forth. But these are relatively uncommon as a pure entity. Certainly, we see myoepithelial cells in association with several other entities. But by definition, this benign lesion should have less than 5% epithelial component. More than that, and you would put it into the pleomorphic adenoma category. These tend to be older, men and women equally affected. And the spindle and epithelial-like cells are usually quite monotonous. In the major salivary glands, parotid, submandibular gland, and so forth, it's encapsulated. But if it happens to occur in the minor salivary gland of the oral mucosa or palate, may not necessarily be encapsulated. Now, the markers that are available to use as myoepithelial markers include S100, GFAP, so something we don't usually think of with epithelial tumors, calponin, muscle-specific actin, P63, and CD10 less specific than these other markers. Now, I noted that in one of the publications, it mentions that if you have these plasmacytoid cells, they may tend to be negative for all of these myoepithelial markers, but you can still, if they're CD138 negative, for example, then you would still use the morphologic features to call them a myoepithelial tumor. There are some fusion transcripts that have been identified, particularly in the oncocytic lesions. So let's take a look at a couple of cases. Here's a case you can see nicely encapsulated at low magnification. Now, this is somewhat of a thick section, but it has a fairly thick capsule as well. And as we come into higher magnification, you'll see there are a few rare epithelial elements here associated with it, but most of it is this pure proliferation of somewhat slightly spindleish epithelioid type cells, streaming, a little bit of nesting, maybe a little bit of vascularity type of change, a little bit of mucoid, myxoid change here. And you can see this might be confused for, an endothelial type lesion or something of that sort. And that's where your markers for myoepithelial cell differentiation would be helpful. So that's sort of one pattern to see and think about, is this sort of spindly pattern with occasional sort of mucoid or myxoid changes, but no, real clear-cut epithelial differentiation. Let's look at another example. Yes. I'm sorry, your audio is not very clear. You want to type your question in the chat?
Breast cancer.
So we'll talk about myoepithelial carcinoma in a few minutes. So let me go on to this case and we'll talk about these others in just a minute. So here we are in a minor salivary gland. You can see the squamous mucosa here. And you can see, some minor salivary gland over here. So this lesion is not quite as clearly circumscribed. And you can see we have more of this very myxoid or mucoid pattern of tissue. But notice that it's still quite nicely lobulated. It's not in a diffusely infiltrative pattern. It's mostly lobulated in this pattern. There's a little bit of, say, more infiltrative pattern here, but the overall appearance is of some degree of lobulation. And you can see there's some chaining and nesting of these cells here along with this mucoid material. Not any really true clear-cut ducts being formed per se. And so, you could say, well, is this a, monomorphic or basal adenoma? But the pattern of the cells and so forth, a little bit of a spindle-ish shape, and your myoepithelial markers should steer you towards a myoepithelioma. Now, of course, this is a fairly large one, and in a minor salivary location, you certainly want to get good local control and make sure that your margins were clear. Obviously, they put some ink on here, but that's going to be a problem if this is the margin up here, because it's right on this is from the hard palate, for example, it could be clearly positive. But this myxoid pattern and the sort of chaining and nesting with this lobulation appearance is fairly characteristic of myoepithelioma. See if we've got another example here. Again, this one from what appears to be a submucosal location. This could be from the submandibular gland. And again, note we have this nice encapsulation, but here you can see a lot of this very myxoid and trabecular type of pattern in some of these areas, little strands of cells with quite a bit of this myxoid background. So when you see this myxoid type of a pattern, always consider myoepithelial lesions. We don't see any high-grade atypia here. You'd want to look for mitoses, of course, or any high-grade atypia, or evidence of infiltrative destructive invasion to make sure that you're dealing with a myoepithelioma rather than not a myoepithelial carcinoma. But usually this nice sharp circumscription, especially if you're associated with other gland elements here, should steer you towards the benign diagnosis. And I think we have one more example. This is one that had been around quite a bit of time. And so you can see that it's become quite hyalinized and sclerotic. So almost more of a pleomorphic adenoma almost, because you've almost got a little bit of ductal type of epithelial remnants here. But this may have been one that was kind of growing out of a pleomorphic adenoma, because as we look at these other more cellular areas here, it's clearly more single cell type pattern. Again, you see this sort of mucoid myxoid change in between the cell nests that sort of fall apart, leaving this myxoid stroma behind. So in this sort of a situation, I probably would, if this was all staining as myoepithelial cells and I didn't see very much of the epithelial component remaining here in this obviously very hyalinized precursor lesion here next door, I might say a myoepithelioma arising from or associated with an old pleomorphic adenoma, depending on the amount of epithelium that I characterized in this area here. I suspect that this is a lesion that had been long-standing, and then the patient noted a change in the lesion, which certainly could be an indication for considering the possibility of carcinoma from pleomorphic adenoma. But in the absence of otherwise clearly malignant features in this lesion, I think you could still classify this as myoepithelioma. You'll see here we don't have any high-grade atypia, didn't see any mitotic figures, and still relatively circumscribed. Okay, so let's go on here to the next one here. One more myoepithelioma, a little bit more of a diffuse pattern. This one partly shelled out. And notice this one doesn't have that very prominent myxoid change that we saw in the others. This is more of a pure spindle cell type of lesion, sort of a spindly nested type of tumor. Now in this lesion, it's so cellular and so forth, and we don't have good evidence of the margins. You could have difficulty in classifying it as a benign myoepithelioma, given that lack of insight on the margins from this particular section. Although you have a little bit of the margin here, it's not really very encapsulated. And so, you know, if you were concerned about this lesion, say, for example, if you saw it in the breast or someplace like that, you know, further evaluation of those margins could be useful in this setting. I don't think this was from the breast. Let me just double check. Yep, it was listed as from the parotid. So this is the spindle cell myoepithelioma from the parotid, but we don't have good evaluation of the margins in this section to see, and not much of a fibrous capsule. All right, so now let's talk about myoepithelial carcinoma. This is a tumor that can occur even in young people, late pediatric, post-adolescent age group, on up through advanced adulthood. As we saw in that previous pleomorphic adenoma case, some of these can arise from pleomorphic adenoma. They're more frequent in the parotid than in other locations. And in this tumor, you like to see necrosis, mitoses, and so forth. And these are the things that portend a bad prognosis. And this is a tumor that has metastases even more frequently than regional spread. So lung metastases ahead of lymph node metastases and so forth. And this is associated with these PLAG1 fusions, as well as EWSR1 rearrangement or HMGA2 fusion. So these are tumors that may have a fairly monotonous morphology, like many fusion tumors do. But because of the other features of malignancy that we've noted here, you would be able to more safely mark them as carcinomas. They will have myoepithelial markers that we've mentioned. They'll also be SOX10 positive and have some cytokeratin expression. So let's look at some examples of this and see if you can discern the differences. So here we have squamous mucosa, salivary gland tissue, and this tumor. We'll look at higher magnification here. You can see a little bit of this rounded and nesting pattern. I think you can also begin to see a little bit more atypia to some of these cells than we saw in that earlier pattern. Notice the clear cell pattern here, and there's a bit more nuclear variation.
Professor,
someone trying to ask a question?
Can you hear me?
Yes, I can hear you.
Can you speak into the mic, please? Network is a bit interrupted, and many people can hear clearly.
Okay, well, I'll move I'm just using the computer microphone, so I'll move it a little closer here. And is that better? Okay.
Yes, thank you.
All right, I apologize. We should have tested the audio before we began. So we'll look a little bit more at this case and see if we can identify other features that identify malignancy. Here you can see one that might be suggestive. This looks very much like you may have intravascular spread. Here, as you see, an endothelial line space here and one line here with subendothelial growth and intraluminal growth of the tumor. Those are usually bad prognostic signs and probably partly explains the behavior of the tumor to have distant metastasis ahead of local or regional metastases. We'll look again for some areas of necrosis. So here you can see again the higher nuclear grade. There are a few mitoses. Here's one. Here's another one. A few more around in this area. And we do have a few small areas of microscopic necrosis here. It's not macroscopic, but there is a little bit of necrotic debris in a few areas here as well. So let's take a look at another case, just to sort of further expand the differentiation. This is an epithelial myoepithelial carcinoma, so it has a little bit more epithelial component to it. And you can see that with these rounded ductal structures. And so this is a combination tumor, if you will, where most likely the myoepithelial component is going to be the more concerning one. So here's a ductal element, and then you kind of have a hard time telling which of these are myoepithelial and which are going to be epithelial cells, which is where your immunohistochemical stains would be helpful. This lesion shows, some extension or spread into beyond its capsule. So it was slightly encapsulated here, but you've got evidence of permeation of that capsule going on here. It's not a very firm marker, but you also see this invasive pattern here, which looks very suspicious for angioinvasion or small vessel invasion, as you can see there. And again, here's more spread into the soft tissues. And then you have this skip lesion, if you will, where this lobule of tumor over here is separated from the main tumor mass by some distance. And again, shows areas at the periphery where you have a more invasive pattern. And here again, you see this subendothelial type growth here extending very close to this vessel in that area there. So this is the sort of a scenario where I suspect if you did levels through the block in this particular case, you would see how this tumor either extends into the vessel or grows immediately underneath the endothelium in some areas. And that is certainly very helpful in defining malignancy in a case where you are looking for additional evidence to make sure that you call it carcinoma. Here's another feature over here. You can see here we have that pattern of subendothelial growth by this tumor within or abutting into this small vessel. So those are features in these tumors that can help steer you towards malignancy in this lesion. And this is kind of a variant on that myoepithelial carcinoma variation. Okay, well, let's talk about another malignant variant in the tumors. We talked about basal cell adenomas last time. Basal cell adenocarcinoma is also recognized and has infiltrative growth, in contrast to the adenomas, which are not. This is a low-grade carcinoma, which generally has a somewhat biphasic growth pattern with maybe other elements, either sebaceous or squamous elements. It's more common in the parotid and usually adults in the older age groups. About a quarter of them arise from basal cell adenomas. So this is why we like to see those excised. and explored. Now, there is a sort of a syndrome that's associated with this tumor, and I won't go into that because that's a little bit beyond what we want to talk about tonight. And immunohistochemistries, cytokeratins, luminal monoclonal CEA, some myoepithelial type markers in P63 or S100, and calponin on the more basal type cells. Okay, so here's a representative slide. You can see it has a bit of seeming encapsulation, but it has a few areas where you could be concerned. So we'll take a look at the tumor cells first off and just see the pattern. Here you see the hyaline material, sort of typical of basal cell adenomas. It has a little bit of these sort of inverted growth surrounding these hyalinized areas. A little bit of more ductal type differentiation here in a few spots. And another area of a few lumens and so forth. So where do we see the infiltrative growth? Well, again, you're going to have to look at the capsule of this to find that. And, this is not something that we can usually detect by needle aspiration. So, of course, if we find a basal cell type lesion or a monomorphic lesion, we're going to want to see that excised to make sure that we're not dealing with a basal cell carcinoma. So here's one area, maybe a little bit suspect for capsular infiltrative growth. And let's see what else we've got over here. So here you see this additional nest off the edge. So, this is not the most clear-cut example of basal cell adenocarcinoma in terms of demonstrating invasive behavior. But you could certainly begin to be concerned for that on the basis of these two nests sort of beyond the usual encapsulation of the lesion, and want to more fully examine it. Here we can look again here, and here again you begin to see a little bit more of this sort of infiltrative pattern of growth. It's not respecting a capsule here. It's not maintaining itself within that very closely, and here growing around a large vessel. So a little bit subtle, but a nice example of the kind of morphology and pattern, the piecework pattern. I think we've got another example of one here. Here we see sort of several nodules. Here's one, and here's one. And again, there's a bit of fibrosis around these tumors, but you can see some areas of, separate tumor away from the tissue. You see this area here, you see this area here, and then of course this nodule over here. So if this is separate and distinct growth, it's evidence of kind of early invasive spread within the gland. Here we've just obstructed the ducts and got atrophy happening here, so that's not tumor. But I think over here you can see there's spread beyond the lobulation into this other area here. Now, this lesion does not have quite the same degree of hyalinized basement membrane that we saw on the other tumor, but I think you can see that there still are sort of two cell types. We have these basal cells around the periphery, and then we have these more central cells. So this is where you'd see a differential staining pattern with the calponin or with some of the other markers that we just went through. These basal cells might stain with the calponin, whereas the epithelial markers might be positive in other areas more towards the lumina. And here you can see a little bit of that hyaline type material here being formed. Okay, so we'll go on to the next slide. Again, another basal cell adenocarcinoma. Here you can see two portions of it. The tumor with sort of an irregular infiltrative pattern margin here, and then adjacent soft tissues with an area of separate and almost intraluminal type tumor. Or maybe this is lymphoid tissue. Oh yeah, this is a little lymph node, I'm sorry. But here you can see the kind of pattern of low-grade infiltrative growth with some desmoplasia in response to the tumor. And again, little tongue sort of protruding through the fibrous capsule in areas here. So evidence of kind of a minimally invasive pattern carcinoma. It is a low-grade carcinoma. And this is kind of what we see. And note also here, this peripheral palisaded pattern is nicely characteristic of the basal cell adenocarcinomas. I think we have another case. Oh, here's one more case. This case here invading a strap muscle and showing more examples of this pattern of infiltrative growth. Notice here we can get some cystic changes in some of these in a few foci with some associated cellular debris. The inverted hyalinized little fibrous cores, another feature. So as I did last time, I'll certainly post the links to these slides so you can study them in detail on your own. So mucoepidermoid carcinoma, something that I'm sure all of you have seen at one point or another. The most frequent epithelial malignant neoplasm in the salivary glands. And it is generally considered to have three cell types that are seen with it: the mucous cells, the sort of indeterminate or intermediate cells, and some squamous elements. Now, this is a translocation-related lesion with a T1119 translocation that results in a CRTC1 and NAML-L2 fusion. It occurs in both adults and children, more commonly in women, both in major and minor salivary glands, as well as, of course, other sites like the tracheobronchial tree and so forth. There are several grading systems in use, and each of them has its relative merits. You can read about those at Path Outlines or other locations, and I won't go through them here this evening. I just want to give you the histologic overview and let you see some slides. So positive stains, cytokeratins, of course. CK5-6 will usually stain the intermediate and squamous elements. P40, likewise, the squamous elements. EMA will stain both. And the MUX 1, 2, 4, 5AC would be positive in the mucoid cells. So this combination of seeing some squamous markers, CK5-6, P40, as well as the MUC stains or a mucicarmin, very useful, simple to do. These are the stains that we most frequently use to verify this diagnosis. Usually our myoepithelial markers like S100 or GFAP would be negative, as is GATA3 in most of the cells. And in contrast to ductal carcinomas, it'll also be HER2 negative. So probably the most useful of all these stains, I would say, is the mucicarmin. If you just had to do one stain, you can usually identify squamous differentiation or intermediate cells using H&E, but the mucicarmin kind of nails it. So if you've got both of those, that's very, very helpful. Okay, so here, let's take a look and see if we can identify the 3 cell types. Here's a somewhat encapsulated tumor, but it's got a little bit of a ragged margin in areas. We see some sort of cystic spaces here, luminal type of picture. And this is where, you want to be able to identify some intracellular mucin, like some of this type of material here, as characteristic of the mucoid component of it. Certainly seeing some blue mucin is very helpful. Most of these cells, however, would be kind of the intermediate cells. Here's a cell clearly with a more blue mucin, a lumen with blue mucin. So you've got the mucoid component here. Do we have the epidermoid component? Well, you'd like to see some squamoid differentiation in areas. And so in a case like this, where the mucus element is easily identified, then you might need to use your immunohistochemical markers to identify the squamoid elements. Because, of course, there are other tumors that can have mucus, and the salivary duct carcinomas, the sort of previously known as the mammary type carcinomas or mammary analog tumors, can occasionally have a mucoid and cribriform pattern like this. Here you see more of the nesting pattern and some infiltration of this tumor. So I'm not seeing really good squamous differentiation right off the bat, but maybe some of these cells would have a little bit more squamoid element here, maybe some of these cells. So more of a muco prominent carcinoma, and maybe here's a little bit of more squamoid differentiation in some of these areas. So not hard to identify the mucoid component in this case. Sometimes it's the reverse, where the mucoid element is very difficult to identify. Here's one a little bit more clear cut with clearly one element over here, and then a more type of glandular element over here. So as we look at these cells, the mucoid element may not be very evident here. We do see some cleared out spaces, but it's not clear if these contain mucin or not. Here's some cells that sort of look like they could be mucocytes, have sort of vacuolar droplets in their cytoplasm. And here a more almost enteric type of differentiation. Coming up here, we'll get into the more squamous elements, and here you see more solid type growth with more clearly squamoid pattern cells, hard cytoplasm, less distinct cytoplasmic margins, and so forth. So nice squamoid and solid type tumor, some intermediate areas, and probably some enteric type mucocytes as well in this lesion. So it fits nicely into that classification. And you can see here we're in probably a minor salivary gland location with squamous mucosa here, a salivary duct coming down into this minor salivary gland, which has been pretty much taken over by this lesion. And it may have started with this sort of mucocele type of appearance here, a low-grade mucoid metaplasia, if you will, with more basal type nuclei in these cells, but then has clearly developed into an invasive pattern with this infiltrative pattern of both this glandular element here and the squamoid elements up here. So kind of a nice insight into the pathogenesis and development of this tumor. One more example, a mucoepidermoid tumor. This one, I think, occurring in the parotid. I apologize for the dirty slide, but you can see the secondary atrophy in the parotid type tissue here with lymphoid inflammation. And then we look at this tumor, which has lots of mucus in it. And you can see again here these nice blue mucin-containing cells. And then the less evident ones with sort of more sharp margins would be more squamoid or intermediate cells. So it's a nice combination of the two here in almost equal proportions. So these are relatively straightforward cases. I think the hardest ones are the ones that are more solid. And this is maybe one a little bit more like that. It's got a little bit of cystic change here. But at the periphery, you see it's mostly this more squamoid element, more of a higher grade squamous. You'd almost even wonder about myoepithelial type of pattern here. And so this is a case where, you know, they're relatively rare mucoid elements, and you might have to stain several slides to look for those elements. And even finding a couple is probably adequate to be able to classify it, particularly in the higher grade tumors like this is. Finding just a rare cell that has a little bit of a mucoid cytoplasm should be adequate to make the diagnosis. Now, I don't know in terms of sensitivity between using the muck stains versus mucicarmine stain. I haven't seen a study that's looked at that differentiation. You might wonder here, did this arise from a Warthin's tumor? You've got this nice lymphoid stroma and a cystic space. So, you know, that certainly would be in the differential for a tumor like this as well. Carcinoma arising from a Warthin's tumor. Let's just take a look over here and see if we've got kind of more classic. Yeah, we almost do have kind of a more classic Warthin's tumor type of appearance here. If I took a picture of this, you might buy it for a Warthin's tumor, given the lymphoid stroma and relatively bland tissue here. One more case in the mucoepidermoid category. Again, a much more solid tumor, fairly high grade. And as you can see here, there's just a little bit of differentiation. You got a little bit more squamoid cells here and more of the intermediate cells here. But I believe this is a mucicarmine stain, just based on the coloration here. So, you know, you can see here how just a little bits of mucin, like right here, stand out with this stain. Here you see another cell here. So the squamous cells here, the intermediate cells, and rare mucocytes, a little bit of positive blush with the mucicarmine stain can be very helpful in these situations. The mucicarmine is not a horribly difficult stain to do. So if you haven't brought it into your laboratory, I would encourage you to consider that because it can be quite helpful in these cases of head and neck tumors when you're looking for these rare mucus positive cells. So this is a nice demonstration of that utility. Because I think if you were looking at this with, you know, a pure H&E stain, it would be much more difficult to convince yourself that this was truly mucus cell differentiation. And here is, I believe, the immunohistochemical stain. That will also highlight the occasional positive cells. As you can see here, here, and let's just verify. I think this is the MUC5. They don't tell us what the stain is, but I'm pretty sure that this is an immunohistochemistry for MUC5AC. Let's see if we've got a control here. I don't see a control tissue here. So take my word for it. This is one of the MUC stains, and it's highlighting the mucus cells in this case. All right, well, how are we doing on time? I think we have enough time to cover salivary duct carcinoma. Because I don't have a lot of examples of this. But this is an important tumor in the salivary glands not to miss, primarily because the treatment is very different than some of the others in terms of prognosis. This is a high-grade neoplasm. So the differential would include things like high-grade mucoepidermoid carcinomas, would include things like some of the myoepithelial carcinomas that are higher grade. But it's, if you want to think of what it's like invasive ductal carcinoma, especially the luminal types. So it often has an in situ component that has comedo-like necrosis. So this was previously called, salivary duct carcinoma or mammary analog tumor. It tends to be older patients, and interestingly, men are more frequently affected than women. It can occur arising from pleomorphic adenoma, but usually does not, but more frequent in the larger salivary glands, submandibular parotid gland. And there are a variety of different variants, just as we see in ductal carcinomas. We have a very mucinous type, there's a micropapillary type, basal-like, and sarcomatoid tumors can occur. Now, in contrast to what we just mentioned, this tumor usually is GATA3 positive. It's positive with androgen receptor, which probably explains the male predominance, but it also stains with some of the breast markers like GCDFP and HER2 in about a third of cases, and maybe even PSA. So it's a really quite interesting array of positive markers here. That includes breast, prostate, and other areas. So quite interesting in that regard. So let's take a look at what it looks like morphologically. As you can imagine, this has a lot of similarities to breast cancers. So an in situ component is possible. And here we'll show you one example. Again, I apologize, the slide is not in good shape. But you can see here we have lobulated salivary gland tissue, intervening fibrous tissue. And then as we look at these ducts, there's a bit extra epithelium here, and there's some sclerosis or some desmoplasia around them, and it extends up into some of the lobular areas. So as we come into higher magnification, I think you'll see that this looks a lot like mammary carcinomas. We have sort of mildly pleomorphic nuclei. We have a cribriform pattern architecture. We have some necrotic debris in the lumen. And as it extends up into the lobular structures, you see it forming a little bit more almost solid type growth, sharply punched out cells, displacing other cells, and here, a good, reasonably high grade type of pattern of carcinoma. So what we saw in this case was pretty much all in situ type tumor with, as it were, cancerization of the lobules, as we say in the breast, and involvement of the ducts. So obviously this tumor can go on to an invasive component. Here's another in situ example with more macrocystic type of change, more central comedotype necrosis. And here you can see, again, the degree of abundant eosinophilic cytoplasm, nuclear variation, a bit of cribriform pattern, and variable amounts of stromal reaction. Okay, here's another example, and here, as you may guess, we're going to look at an invasive pattern. So here's the tumor cells. There's associated sclerosis. There's separation of the tumor cells around this. And you can see they're quite nicely epithelioid, a little bit of small luminal space, mitotic activity here, as well as some areas of more suggestive of still in situ type of tumor extending into some of these areas. Here's a more in situ type pattern of ductal type involvement, and then involvement of these lobules with areas of apparent invasion into the surrounding stroma. Now, this could all still be cancerization of the lobules if you didn't see areas such as we have down here, where you've clearly got a more invasive pattern extending around small vessels and obviously going to your intrasection margin with this infiltrative pattern in between dense collagen here. So you see this type of a pattern is not something that would be compatible with an in situ type of lesion. So it looks very much like breast carcinoma. When you see that appearance, think salivary duct carcinoma and think that array of markers. Here's another example. Here you can see it tends to involve just this lobule of the parotid here, but we've also got areas over here that may be involved as well. As you can see, there's a destructive pattern here in this area of the tissue. And we'll go over here and look at this pattern. And you can see this is clearly an invasive lesion, high grade appearance, nearly solid growth, with some adjacent, almost spindle shaped type of pattern. So the beginnings of a transformation to almost a sarcomatoid element. Another example here, as we look here at this case, you again see the sort of more classic punched out pattern of a mammary-like tumor, sharply nested areas surrounded by this little thin rim. That's a retraction artifact. And you see quite a bit of pleomorphism to these cells as well. So an invasive pattern, invading the parotid, invading lymphoid tissue, coming close to your margins here. So I'm going to stop here and we'll take any questions. Let's see, I've got a comment here, so I'm going to take a look at the question here. So the question, a very good question, Dr. Lin, how to distinguish epithelial or myoepithelial carcinoma from mucoepidermoid component carcinoma when the mucoepidermoid component has no obvious squamous component. So myoepithelial carcinoma should not have the mucus positive cells. So you should not be able to identify the mucin positivity or the muc positivity in those cells, in those tumors that you have in this. Additionally, you can use your myoepithelial markers, such as GFAP or those sorts of things, which will be positive in the myoepithelial tumor usually, and not in mucoepidermoid carcinoma. So a limited panel of a couple of myoepithelial markers, a couple of squamoid markers, a mucicarmin or a muck should be able to get you that distinction between those neoplasms. Good question, very good question. Other questions?
Thank you, Professor.
Okay, well, you got a busy day ahead of you and a weekend ahead. I'm glad to have you here and thank you so much for your attention. And I'll post the recording and the link to these slides later as soon as the file is converted so you can review it or share it with others as you see fit. And we'll look forward to doing it again next month. We'll finish, hopefully we'll finish salivary tumors next month. We have still a few more cell types to do. So have a great day. Nice to see you.
Nice to see you. Thank you, Professor.
Bye-bye.